Data or knowledge that we gained, and I have to admit though, but Professor Poo addressed that correctly. Okay, so not everyone of my family is here. My two oldest sons that we cannot see right now.
Please answer.
趁这个时间的话，随便你做什么，就把他们当小事了。他懂中文，他会讲中文啊，所以等一下呢，这个大家可以跟他去聊聊天。那还有2位哈是这个 Jenny 的父母，也是我们 Toby 的岳父。
So now you know my whole family. Okay, well, also Professor Poo told you a little bit about the Martini Clinic. It's really only dedicated to prostate cancer care. It was founded in 2004, and we offer actually everything from diagnostics to local therapy, also systemic therapy now in combination, of course, with the medical oncologists, scientific research. So just to give you one number, is really radical prostatectomy is the most striking number. We perform 2,500 cases each year in our institution. So yeah, it's solely dedicated to prostate cancer, and that's why I'm very happy that I could join last year this team, and also on the basis of PSMA. And so I'm very happy with this molecule that it was there. So what I want to address in my talk is first, just very briefly, some things about PSMA PET in prostate cancer. Then I will also touch briefly primary staging and restaging of recurrent prostate cancer. I think most of you probably know a lot of these data. So I will then more focus on the impact of PSMA PET on clinical management, and then also talk about targeted approaches.
So can you use the slide control?
Oh.
So that you don't have to get close to the table.
Okay. And then touching PSMA radio-guided surgery and also PSMA radioligand therapy. What I think is also very important to know the pitfalls when you look at those images, and so I want to share with you some information that we obtained there, and also what is on the horizon, what is next. So first, PSMA PET in prostate cancer, you know it's a membrane protein with a large extracellular domain. It is expressed, significantly overexpressed in a lot of prostate cancer cells. Over 90% of prostate cancer cells have a significant overexpression, 100-fold, even 1,000-fold. And this makes it a promising target for imaging as well as therapy. And various ligands have been developed, and here are just some of them. And you see gallium-labeled ligands. The most widely used ligand is PSMA 11. Probably also in your institutions is used. It was first developed in Heidelberg, in Germany in 2012. And that was really the ligand that makes it or made it around the world. However, now there are also newer fluor-18 labeled ligands around, PSMA 1007 or RH PSMA 7, for example. And these ligands are interesting because they lack urinary excretion, so you don't have tracer in the bladder. And especially when you look at recurrent prostate cancer and you want to know, does this patient maybe have a local recurrent disease? These traces might be of advantage for you. Primary staging, and a focus here on briefly on lymph nodes and bone. This was one of our first studies, looking at 130 patients, preoperatively performed a PSMA PET, and then did a template-based lymph node dissection. And I just have here a sample case for you. These are, of course, high risk or at least intermediate risk patients. He has a lymph node metastasis here in the obturator fossa. This is a lymph node that would commonly be treated by surgery or radiation. cover a normal field. However, there is a lymph node also seen in this patient behind the psoas muscle outside the common fields. So this would not have been treated. This guy received surgery. He had actually another lymph node lighting up. He had the 3 lymph node metastases out of 40 removed lymph nodes. So when you look at now the statistical values and compare morphological CT MRI imaging with the PSMA PET, you see that especially specificity rises very high, and also sensitivity increases. Of course, PSMA PET is not perfect, and I'll come to that in a minute. However, I just wanted to share with you, you can also use this information not only for surgery, but also for planning of your radiation fields. And in this study, in 1/3 of patients, the planned target volume changed due to the results from PSMA PET imaging. PSMA PET, I said that before, is not perfect. And this is a really nice work from colleagues from Freiburg, and also south of Germany, where they looked at the size of the metastatic lesion within a lymph node to become detectable by PSMA PET. And they found that it takes around 2 millimeters size of the metastatic lesion, that 50% of those lymph nodes are seen. And if they are larger than 4.5 millimeters, the metastatic lesion, then 90% and more are seen. That means smaller lesions will be missed, and you have to keep that in mind, especially in primary staging, where it is more likely when you have 1 or 2 lymph nodes lighting up that you might also have a micrometastasis somewhere else. However, it's a lot better than CT or MRI, and the common criteria here are a size of at least 8 to 10 millimeters. When you look at bone, this is the same patient. Of course, all the lymphatic disease cannot be shown by bone scan. But when you just look at the chest, you see those small lesions that cannot really be seen on bone scan. So we compared here bone scan with a PSMA PET in 126 patients. Actually, we very early on omitted bone scan if we had a PSMA PET available. So it took our database to screen 2,300 patients to find those 126 patients who had both examinations. And we found that only 5 regions were suspicious on the bone scan, but not on PSMA PET, which changed the bone status in 1 patient, but 72 regions were only suspicious on PET. And this changed the status in 10 patients. So PSMA PET actually may serve as a one-stop shop examination, giving you all the information about bone, about lymph nodes, and a skip that about local tumor. Like in this example, you see a small lymph nodes that hardly show up on the conventional imaging, and then you see bone lesions that can also be seen on bone scan, and maybe even smaller lesions as well. Restaging of recurrent prostate cancer. I think this is really the main value of PSMA PET, where it changes the most. And this is a study that we earlier on could publish in 332 patients with recurrent prostate cancer after radical prostatectomy with a PSA not below 0.2, so not the very early recurrences, and also we excluded patients who had already castration-resistant disease. The median PSA of all those patients was 1.67, and most of those patients received a PET CT scan. And the good message is PET CT scan is absolutely enough. You don't need PET MRI, and I personally think PET MRI is rather a research tool than a really clinical investigational tool. You see, on the other hand, that even at low PSA values, 0.2, 0.5, or 0.5 to 1, you have detection rates of lesions in 50 to 70% of patients. When you now compare, however, PSMA PET to CT or MRI, you can also appreciate that 30% of patients have only positive lesions on PSMA PET, while only 3% of patients have only positive findings on conventional imaging. Additional findings in different organ systems, for example, 20% versus 6%. And those small lesions, or the lesions that can only be seen on PSMA PET, what are they? Mainly small lymph nodes or local recurrent tumor. This is the first meta-analysis by Pereira, and he just recently published a second follow-up paper, also in European Neurology, gathering more data. But you also see here, 50% detection at 0.2, 56% detection at 0.5, and 7% detection rate at 1 nanogram per mil. So really early on, you detect positive findings with PSMA PET. And even, and this is now, we could publish this just actually, last year. This is now a study in 272 patients with after radical prostatectomy with a PSA very low, below 1. So we looked again at the detection rates at those different PSA ranges. See 55%, 74% of patients show positive lesions, and now because the numbers are now increasing, also the confidence intervals are much narrow. So we're getting closer to the truth, so to say. So the detection rate, of course, clearly increases with higher PSA values. And you might even find non-regional metastases. Bone metastases in these patients, 25 to 30%. Or non-regional lymph nodes, 7%, and even visceral metastases. So even in this very early biochemical recurrent prostate cancer patients, you have these findings. And this changed actually now the new European Neurology Association guideline. And they clearly now state, before that it was side by side, but they clearly now state to use PSMA PET after radical prostatectomy if you experience biochemical recurrence, and at the end of this sentence, if the results will influence subsequent treatment decisions. Actually, this is true for every diagnostic test that we perform. But that has to be added, of course, since not everybody, even in Europe, has access to PSMA PET. It's a weak recommendation, level 2B evidence. After radiotherapy, also PSMA PET for staging. If you decide, if you want to go for local salvage treatment, you want to rule out metastatic disease, use PSMA PET. And this is even a strong recommendation. So how does PSMA PET now impact our management? Well, imagine driving in a car in a foggy window. You might not feel so comfortable, but this actually is true how we treat prostate cancer patients. These are all 3 patients with a PSA below 1 in biochemical recurrence setting after radical prostatectomy. I think you would prefer to sit in that car. It's a Tesla, but it's a matter. And you can use now PSMA PET showing you, okay, this patient has a local recurrent tumor, is probably best treated by local radiation therapy. This one, you can have an hour-long debate on what to do with this guy because he has only a solitary nodule in the colorectal region. What to do with that? And this guy even had a bone lesion, all with PSA below 1. This is a nice study from Australia by Roche. It's a prospective study where they examined the impact of PSMA PET on the perceived management of those patients. And they found, even at low PSA values, in 60% of patients, the physician said, well, I would treat now this patient with this information differently. This is another paper by Han and colleagues from Korea. And they also showed that in 55% of patients, the management changed after the results of PSMA PET, again in the biochemical recurrence setting. This can, for instance, influence radiotherapy. You see here, 100 patients, PSA low, 1 nanogram per mil, median. They change the target volume in 60% of patients. For instance, here, the small lymph node, which can now be covered with a boost radiation and be treated. If this will benefit oncological treatment, we actually don't really know yet. We assume it will, and we treat patients like this, but there's not enough data right now to say this patient will really have a benefit. We believe so, but the data has to be gathered. Now you can also use PSMA PET for other targeted approaches, and I want to briefly talk about PSMA radioguided surgery, because you can not only have ligands for PET imaging that you use with positron emitters, or radioligand therapy, and I'll talk about that in a minute. When you're coupled with lutetium or actinium, for example, you can also couple with gamma-emitting isotopes and do SPECT imaging if you don't have access to PET, or do radioguided surgery. The challenge in salvage surgery is really to find those small lymph nodes that can be detected by imaging. Here on MRI, you don't really see it. If I add now the PSMA PET, you see that it's this small lymph node that is actually suspicious on imaging. And radioguided surgery works now this way, that the patient first has a PSMA PET with a solitary nodule, for example. Then a discussion is done with the patient, because it's an experimental approach to do salvage surgery in these cases, and he has to know that, of course. So very careful patient selection is really key to this procedure. Then the patient gets an injection of now technetium-labeled PSMA ligands a day before surgery. Technetium has a half-life of 6 hours, so it can distribute throughout the body and get taken up into the metastatic lesion. For example, here, this small lymph node. And then here in surgery, you can use a gamma probe, giving you a noise signal and giving you a number signal that you can also see. And then you can find this lymph node, which here on PSMA immunohistochemistry is clearly metastatic. And also one slice of this lymph node was just put on radiographic film overnight. And then you also see here the tracer that colors the radiographic film. And I have a short video now, also about the first case, about the MRI case that I showed you, and I hope this works now.
Okay.
It's working. So you see here the sigmoid that is taken away. Now the gamma probe is inserted. You have some background. But you can clearly appreciate where the metastatic lesion is. Of course, also this technique is not absolutely accurate. You might find lymph node metastasis up to 2 millimeters, but you can then also, after resection, immediately prove if you found a lymph node. And you can even do that on the OR table. So you don't need to worry about frozen section analysis and wait if you have found really the lymph node. So this was a maybe 8 millimeter metastatic lymph node, and otherwise no other metastatic lesions were seen in this patient. What are the results of this experimental surgery? We could just publish in the European Urology this year. This is the best PSA response. It's a PSA decline over 50%. It's 77% of patients, over 90%, and roughly 50% of patients, and a complete biochemical response. We call it a PSA drop below 0.2 in 66% of those patients. This is the PSA recurrence-free survival. Of course, not all of those patients reach the or fall below 0.2 nanogram per mil, but the patients that actually are going very, very low with the PSA after surgery, they experience a PSA recurrence-free survival without any other treatment, no hormones given, no radiation given, of 20 months. This is the therapy-free survival for all patients. So all patients had 26 months median, no other therapy for prostate cancer. What are good candidates? Of course, no PSA, one single lesion on PSMA PET. These are probably the good candidates, but we're going much deeper in analysis as we gather more data. Now, last year we were also able, I showed you open surgery, to do robotically with a drop-in gamma probe, which is also still experimental, so it's not commercially available, with our colleagues from the Netherlands. And so we did the first 2 cases at Martini Clinic with robotically. And this again, I think, is a look into the future where it might be in a few years. So now, on the other hand, with the metastatic prostate cancer patients, what can we offer them? Well, there's lutetium radioligand therapy. You all heard and know about it. There are actually 2 traces, PSMA 617 and PSMA INT, that are used, and there are increasing number of retrospective case series or case studies which all show a good PSA decline, over 50% in roughly 30 to 60% of patients, and also, and this is the key point, a good tolerability, less side effects by this treatment when you compare it, for example, to chemotherapy with docetaxel or paclitaxel. This is, of course, then a showcase. This was one of our first 20 patients who showed an exceptional response, a complete response in a patient with really a lot of prior therapies, docetaxel, ABI, ENSA, radium-223, and then after 4 cycles of lutetium PSMA, his scans were actually normal, and his PSA dropped to 0. In the meantime, this patient, after I think 1.5 years, he experienced recurrence. However, this was a basically almost end-stage patient. So you can have those complete responses, of course, not in all of those patients. We now published a paper of 100 consecutive patients, all with metastatic castration-resistant prostate cancer, who were previously treated at least with ABI or ENSA, and at least with 1 line of chemotherapy, docetaxel, or who were unfit for chemotherapy. And all of those patients had, of course, had to have a positive PSMA PET scan at baseline. This was the treatment regimen that we applied to those patients. Lutetium PSMA was given every 6 to 8 weeks. First, we started with an 8-week period, but then we shortened it because we saw already progression at the end for up to 6 cycles. Now we also have patients that we retreat again. Concern was toxicity to the salivary glands, dry mouth. However, we did not see it. Concern was also deterioration of kidney function. Also, we could not see that. So it is generally well tolerated. Mean activity was 7.4 gigabecquerel. These are the patient characteristics. PSA median 165. And when you look at the lines of prior systemic therapies, most of those patients had at least 2 or 3 prior regimens after hormonal treatment. And this is also a little bit different to the study by Michael Hoffman from Australia. We had more patients, 1/3 of patients actually had distal metastasis, and all of them basically had bone metastasis. These are the treatment emergent adverse events. So you see only grade 3-4 hematotox and immunoneutropenia and thrombocytopenia, but other than that, the treatment was really well tolerated in those 100 patients. This is the best PSA response rates, a PSA decline over 30% in 47 patients, over 50% in 38 patients, over 90% in 11 patients, in those really almost end-stage patients. This is the progression-free survival and the overall survival. Of course, again, these are sick patients, so the median overall survival was 13 months, but they actually didn't really have any other line of therapy available. What are baseline prognostic factors for PFS or OS? We found visceral metastasis is basically, when you look at the hazard ratio, the single prognostic factor that we could evaluate. LDH is also highly significant. However, when you look at the hazard ratio, it doesn't really play such a big role. When you look now at visceral metastasis, yes or no, again you see here the curves separate nicely for progression-free and overall survival. When you're in treatment and you see a PSA response over 50%, then also, you see this patient is a good patient for this lutetium PSMA treatment. So they perform a lot better than patients who do not show PSA response. This was on the cover of the Journal of Nuclear Medicine in 2016. The colleagues from Heidelberg, after lutetium PSMA and the group around Haberkorn, Eder, and they developed even radioligands labeled with alpha emitters, like radium-223 is an alpha emitting isotope. So in very short distance, a lot of energy is transferred to the metastatic lesions. And this is a patient progressing under lutetium PSMA, and then he received actinium PSMA, which wiped out the disease in this already pre-treated patient. And they published a series of 40 patients, PSA decline over 50% in 63% of patients. However, when I go back now, the alpha-emitting isotopes, they also wipe out really here the salivary glands. So those patients have dry mouth. They do suffer from toxicity, and with actinium PSMA, it is highly regulated because it's an alpha emitter. So in Germany, there are only 3 sites allowed to do actinium PSMA. One was Munich at the time when I was still there. We also applied this therapy. However, in our hands, maybe those patients were still sicker than the lutetium PSMA patients, but we did not really see so good responses because probably the patients were too sick for this kind of therapy. However, it's very potent, but you have to be careful with the dry mouth. So to conclude the radioligand part, it has general low toxicity. You see a PSA decline over 50% in roughly 40% of patients. PSA response at 12 weeks predicts overall survival, progression-free survival, and if you do a subgroup analysis, visceral metastasis is associated with unfavorable outcome. Limitation, of course, retrospective series, prospective series are running, and trials are curing patients. Actinium PSMA might be an option for lutetium PSMA refractory disease. This is how we see it. However, I think this is really limited by the limited access. Now, common pitfalls. I think this is also a very important issue when you look now, going back on PSMA PET scans. One is that is very important are ganglia. Retrocutaneal ganglia or presacral ganglia, they can mimic lymph node metastases. And they also show on immunohistochemistry PSMA expression. However, it's normally a lot lower than lymph node metastases. So this is one thing you need to be concerned about. Then you have inguinal lymph nodes, and these can be enlarged. These can take up tracer unspecifically, And this one is not really that positive, but it was a touch positive. However, inguinal lymph nodes might show up on PSMA PET scans, and even with this newer tracer, with fluo 18 labeled traces, this might even be more pronounced. So you have to be really careful with these lymph nodes. This one was histologically confirmed to be non-metastatic. And then ribs. Ribs is also a hard diagnostic battle for the nuclear medicine physicians, because you have a lot of unspecific changes in the ribs. In this patient, and I got these images from Chile Santiago, this patient was actually operated from the rib. You can argue about if you want to do surgery on this kind of patient, but it showed fibrous dysplasia. It was not metastatic. And this again, where the ribs might be more pronounced with the fluo 18 labeled tracers. And then there are a lot of other benign lesions. And why is that? PSMA is not so specific like the name suggests. PSMA is also involved in neovascular tumor, for example. So here you see a schwannoma. It might be a thyroid adenoma, morbus phagia, tuberculosis, in incidentaloma, sarcoidosis. So there are a lot of other diseases that also show up on PSMA PET, and also malignant lesions. This one, when you look at the CT scan, you would not suspect this is a metastatic prostate cancer lesion. You would say, well, this is a lung cancer, and you're right. But it also shows up on PSMA PET. But it has been shown for hepatocellular carcinoma, renal cancer, thyroid carcinoma, and there are a lot more to come. However, when you then look at the distribution pattern and at the PSA velocity and take all together all the clinical variables that we have, then you might see, okay, this is due to prostate cancer, and then you might confirm your diagnosis a lot better. And then there are PSMA negative tumors. This is a big tumor. You see the diffusion restriction on MRI. And this happens in up to 10% of primary prostate cancer. And maybe in recurrent prostate cancer, I would suggest roughly 5% of prostate cancers are PSMA negative. However, on the other hand, and I mean, you all know that, but you shouldn't mix up PSA and PSMA. These are totally different molecules. And if you have a primary, very aggressive prostate cancer that does maybe not show really a PSA in the blood, a low PSA, then a PSMA PET might be a good chance to follow up this patient if you know if it's PSMA PET positive. So in those kind of patients, aggressive tumor, low PSA, I usually recommend also for primary staging a PSMA PET scan if available. And then you can use it for future examinations. So what is on the horizon? PSMA or PET in general? For one, what we need as urologists and also as nuclear medicine physicians, standardization. This is a study done with FEBU PET from Austria. It's 12 different specialized PET centers. And what they did, they put a FEBU phantom in the PET scanner, and they have different protocols how to do it, and this is the results that you get. You would suspect this phantom study will always give you the same results. It is not like that. And this is actually I would call it low contrast PSMA PET scan. This is a lymph node metastasis. It's histologically confirmed, but I guess if I tell you that that's a lymph node metastasis, you will not believe. So it is important to have standardization for the PSMA PET procedure, and there is a first joint procedure guideline from the European and the American Nuclear Medicine Society describing how we should perform a PSMA PET scan. And then there's also, when reporting, when evaluating a PSMA PET scan, guidelines how to do that. And then I think this is a very good tool for us urologists, at least to understand what the report really shows. It is standardization of the PSMA PET scan to give you a molecular imaging TNM classification of the tumor. So what you do is you have a lesion, you first look at the PSMA expression score. You have the thyroid gland, which takes up a lot of tracer, you have the liver, you have the bloodstream, and then you can have first assign a PSMA expression score to that lesion. And then, and I have not shown that, but in that article then it's clearly shown how to judge then a lesion based on the PSMA expression score and based on where it is located. But then you can describe the local tumor. Is it unifocal? Is it multifocal? Is it capsule penetration 3A or 3B? And us urologists really readily understand this kind of language. Then how many lymph nodes are involved? Or is it metastatic lymph node involvement? Is it only a 1B unifocal osseous lesion, oligometastatic disseminated, or is it already a diffuse bone marrow infiltration that is present? So this helps us. Then the other thing that I'll talk about that already are the tracers. We now work mostly with gallium PSMA 11, but newer tracers, for example, PSMA 1007 or the RH PSMA 7, that lack urinary excretion might be better. Might be better for evaluation of local recurrent disease. Here's a local recurrent disease that is clearly clearly visible on the Flu 18 PSMA PET scan, but not so easily seen on the gallium PSMA PET scan. Furthermore, Flu 18 positrons also travel not as far through the tissue until they give you the signal. So actually the image quality is also a little bit better, a little bit sharper. And this is also a nice example from Hamburg now. With old machines, new machines, and I think I can show you a lot of what I was talking about. So this is the old Philips Achiever PET scanner. This is the new Verios system that was installed, actually this year. This is the same patient scanned with PSMA PET in recurrent prostate cancer setting. Nothing was found. Then a scan with a new scanner, also nothing was found. And then rescanned several months later with contrast enhanced CT with a new scanner, and this was without IV contrast. So here you could not see where is urine. We assume this is urine. And where's bladder wall or maybe tissue. And here you see this is urine, and this here is contrast enhancement. And now we also use the new tracer, which is not excreted in the urine. So this tracer is excreted in the urine. It's extremely hard to find this local recurrent tumor. But now we have the tracer, we know when it lights up here, of course it has to be metastatic, and we have the confirmation by the contrast enhancement. And when we look now back here, well, it was present here as well. So my message is you have to look at your equipment. The hardware should be good, once. If you perform an expensive investigation like a PSMA PET scan, I would recommend to use contrast material, at least if you want to know if it's a local recurrent tumor or not, so that gives you maybe hints, even if you don't have access now to the newer tracers. But I think in the future we will have a Flu 18 PSMA tracer, which one we don't know yet. How to evaluate scans? Also, there has been a lot of work going on, and for example, to do automatization of those PET results. And you could use, or for example, develop a PSMA PET index, like the bone scan index, giving you the whole tumor volume by maybe here just taking all the bone volume and then assigning at a certain SUV. Okay, this is a positive bone volume, and then you can calculate the whole tumor volume. And this could be interesting if you do therapy assessment. If you have a metastatic prostate cancer patient, you treat it, you have a PSMA PET scan before and after, and you say, now the tumor volume was, I don't know, 250 millimeters, and now it's 50 millimeters. Everybody understands that. And then, and I think this is a really awesome, very, very nice slide that I got from Terry Jones from UC Davis. They are developing a whole body PET scanner. And this is not only a larger PET scanner. What it can do is it increases the sensitivity 40 times, and you can use a minimal amount of dosage. You can even examine children. You can examine pregnant women with this PET scanner because you use so much dosage. What it does in all the PET scanners, if you have a signal, it can only detect the signal that goes here up and down. In these PET scanners, or in this PET scanner, you can also detect signals that go this way. So here's just an example, an image of an ape, which was visualized by this new PET scanner. And this image really doesn't have much to do with the PET images that we're used to look at. So this machine, of course, is in development, but I'm very, very excited. Well, if it is available, but it will not reach you. Okay, this is my end of my talk, and thank you very, very much for your attention and again for the invitation.